And fibromyalgia, if you think of the name, fibro, meaning the soft tissues, the muscles, the ligaments, the tendons, the fascia. Algia means pain. It literally translates to pain in those soft tissues, muscles, tendons, ligaments, fascia. The name is a misnomer because classic fibromyalgia is pain, but it's not pain in those tissues, it's pain perceived in those tissues by the brain. It's a very different animal. Classic fibromyalgia involves central pain processing disorder. Means you don't perceive pain the way, or sensory stimulus, light, touch, whatever it is, the way the average person does. You amplify it, you perceive it as pain. There's known reasons why that occurs. We know which neurotransmitters are involved. We know that there's aberrant patterns in the stress response, and that these things are developed over time. There's strong correlation with true fibromyalgia and early stress in upbringing. So being in situations when your nervous system is developing, when you're very young, where you don't feel safe, where you feel threatened, for instance, really bad relationships with parents, really rocky family histories when you're young, particularly if there's abuse, verbal abuse, physical abuse, sexual abuse, but even just the feeling of being threatened. So if you have a violent father, let's say, and you're a little girl, alcoholic, violent, kind of, yelling, screaming, male figure in particular, those people, when they go on into young adulthood, have a strong predilection of developing disorders with a strong central processing psychological root to them. The nervous system is sort of developed in this scenario we called hypervigilance. They're sort of always, where's the next threat coming at me? And it almost gets locked in that pattern. And they have the same kind of patterns that are abnormal in the way their brains behave and their neurotransmitters react to stress that someone with post-traumatic stress disorder has. And we think of that as, people who've been in battlefield situations or experienced a rape or some horrible traumatic event. And it can occur in that kind of thing as well. And some of those folks go on to develop classic fibromyalgia. But the vast majority of them are women. Okay, fibromyalgia has an incidence of at least 20 to 1, women to men. Some of that is the way it's diagnosed, because women perceive pain to pressure when you challenge them more so than men do. Even normal, women and men without any kind of pain processing disorder or fibromyalgia. But women, when they're in stressful situations early on in the development of their nervous system, tend to develop these type of patterns much more so than males do. And there's just a difference in the way the sexes behave neurologically in response to stress. And we see that, right? When males get super stressed, they tend to get very short-tempered, they get frustrated easy, they can often react with violence. Look at, you don't see women setting the mass murder record in a fast food joint, right? Or, they just don't do that kind of stuff. Men do, women don't. Their nervous system spins off into different types of directions in certain situations. Women internalize it more, and they tend to get fibromyalgia. They tend to get something called irritable bowel syndrome. Irritable bowel syndrome is fibromyalgia in the gut, essentially. The intestines have their own independently operating nervous system called the enteric nervous system. It works alongside the central nervous system, which is the brain and all of the nervous system proper we think about, but it actually carries on its own business independently. It uses the same neurotransmitters. For instance, serotonin is a major player, so is norepinephrine, in fibromyalgia and classic pain processing disorders. It's also a major issue in irritable bowel syndrome. I wrote an entire chapter on the linkage between fibromyalgia and irritable bowel syndrome in a medical textbook known as Integrative Gastroenterology, which was done by a gastroenterologist, Gerard Mullen, out of Johns Hopkins. And now that's actually being used in the curricula of various medical schools so that these concepts are better understood. But there's a very high concomitance of patients having both fibromyalgia and irritable bowel syndrome, because it's essentially the same dysfunction in two different nervous systems in the same individual. So we now know what neurotransmitter abnormalities to look for, and we know how to manipulate that system a little bit. These patients also with true fibromyalgia or classic fibromyalgia have a problem in the dampening of pain or their perception of sensory stimulus. There's a system known as the descending antennoceptive system, which goes a little bit haywire in this type of aberrant pain processing. And let me give you an example of your descending antennoceptive system. In the morning, when you got up, you take a shower, you put a shirt on. You perceive somehow that I did not have a shirt on a second ago, and now I have a shirt on because you felt it, right? There is a sensory stimulus that came into your spinal cord, up through your spinal cord, to your brain, and registered to you cognitively, I have a shirt on. Do you want to be told all day by that same nervous system, you have a shirt on, you have a shirt on? By the way, if I didn't tell you already 50 million times, you have a shirt on. It would drive us nuts, right? Because we're always under stimulus bombardment. Yeah. So our nervous system has ways to close the gates, to dampen it. And this descending antennoceptive system basically sizes things up and says, okay, we let him know already he has a shirt on. It's not a threat to him. He doesn't need to know anymore. It shuts it off, okay? So now you're ready for the next stimulus. But if that system doesn't work, things amplify and get out of control. And that's what happens in these patients. They get hit by their stimuli as it's a panic event, essentially, because their whole life has been a panic event. It fits, right? So we know how to test this. There are now drug agents, but there are natural agents that are very good at dealing with this. But they have to deal with some of the old psychological baggage. So when I manage a true classic fibromyalgia patient, I have a team approach. I have therapists, psychologists, in some cases psychiatrists, and it's not to say these people are crazy, it's all in their head. It's just a component of their true disorder is because of psychological overlay of experiences they've had in their life. And it's almost like they have to process those out, or else it's a scab that keeps getting picked. So you have to deal with it on that side of the equation, as well as dealing with it in the biochemical realm. There are drugs such as the selective serotonin and norepinephrine reuptake inhibitors, which are classes of antidepressants, but they also help you sleep better, and you go through different stages of sleep, which fibromyalgic patients have a hard time doing. And they change your perception to pain. Those drugs are probably the drug of choice if you're going to use a pharmacological approach. But there's also drugs known as the delta-2 ligands, which are sort of a new use of anticonvulsive medications. They do work in many cases of classic fibromyalgia. Unfortunately, they have a side effect profile which is not desirable. But sometimes we don't need to resort to those things. We can get them sort of dealing with the psychological side of it, but also engaging in calming routines, meditation, yoga, prayer, more, less hustle bustle. Those patients are not very good. And by the way, they tend to be the type A high achievers. So they have all this stuff in their background. They're already in hypervigilance. And now they're trying to work full time in the financial markets in New York, commuting, and they have children, and they're just burning the candle at both ends. And oftentimes they can get away with it in their 20s, even in their 30s. They start hitting their 40s, and they crash and burn big time, and that's when they come in. But we can use calming agents. There's a lot of botanicals that are great GABAergic, calming botanicals, things like valerian, passion flower, even chamomile. These are great botanicals, but we use precursors to help the body make more of the calming neurotransmitters. Things like tryptophan or 5-hydroxytryptophan that generate more serotonin are very, very helpful. Melatonin to help them sleep at night and get into stage 4 sleep. But things like L-theanine, phosphatidylserine, these are all known as calming nutraceuticals. They'll tend to make you make more calming neurotransmitters like GABA, or they'll actually hit receptors for those neurotransmitters, which essentially calm down the nervous system. Sometimes giving these patients these neurotransmitter precursors at the right dose, some of these calming botanicals, having them engage in some of the lifestyle modifications. Maybe they can't have that job at the stock market anymore if they want to be healthy. They need to just have a more ordered, calm life. And sometimes it's using the medications along with the counseling. But you can usually find a plan for that unique individual that makes them significantly better, if not total recovery.
Just help us out again and where we can find more information about your practice, or Cell Fuel, which we talked about earlier.
Yeah, thank you. You can find out more about my private clinical practice at just drdavidbrady.com. That's drdavidbrady, B-R-A-D-Y.com. And there's a tab on there for my private practice, but there's also an articles tab, a podcast tab with all kinds of resources, different papers and articles I've published, different media appearances where I talk about issues including fibromyalgia, including autoimmune disease, and other types of issues. For the Cell Fuel project and the Cell Fuel program, you can directly visit cell-fuel. So just cell-fuel.com. And you can learn more about the University of Bridgeport and its programs just at bridgeport.edu. And the clinic system, if you're interested in being a patient in the University of Bridgeport's integrative clinics, just at ubclinics.org.